Then we come, I'll not miss a chance to discuss one or 2 points about Mylotarg, and going back to the numbers and these 5 trials where the question was, does adding it in various ways to standard chemotherapy of various types benefit? This was the meta-analysis. From this was chosen by Pfizer, the Alpha group, the French group study, where they gave it day 1, 4, and 7 induction and a single dose of 3 milligrams on day 1 of consolidation. Now, they capped the dose in these days when the vials were 5 milligrams at 5 milligrams. It's now capped at 4 milligrams. Now, my spies tell me that the French do not use that day 7 now because it's associated with quite significant thrombocytopenia in consolidation. And so the issue, I think, for dosing is not the milligrams, but the number of doses you should give. And also, it's not clear from this design whether a benefit is come forth because of the consolidation effect. I think the ECOG study and our studies where they were randomized to receive it in consolidation showed no effect whatsoever. So you've got to talk around about induction, I think. The meta-analysis, now just to make another little point about this meta-analysis, this did not just take the publications. This went back to the data sets, followed the patients, got updated data on individual patients, and so the result was different. And you can see the top 2 studies both became significant, whereas AML-15 overall, when it was published, was not significant, but in long term it was. And it's a very clear statistical picture showing a benefit in survival terms in every but one study. The one study, of course, being the SWOG study for post-approval, which was unfortunate. And here is that's been shown before, the CBFs. So you've got a problem now. You know that it's a good idea to give gemtuzumab in your first induction course to your core binding factor leukemia. So you've got to find out quickly who your core binding factor leukemia is. So I suppose you could do that with FISH and get the answer so that you can give the gemtuzumab on day 1. Alternatively, could you just give it in the first day of course 2? And for a while we had to do that, and I haven't got the slide here, but the outcome of giving it in day 1 of course 2 rather than day 1 suggested that in fact the outcome would not be quite as good. So it goes to one of the challenges that Harry made. If you need to know this patient's got CBF, you're going to have to get the labs to gear up and tell you about this. Poor risk, nothing happening. And again, in our experience, you're not doing these patients any good, but you're not doing them any harm. So we now give every patient in the trials gemtuzumab because it's still licensed in Japan and we get it from Japan. Now, as to the issue of 3 milligrams, 6 milligrams, however, we did a large randomized trial and showed absolutely no benefit in giving 6 milligram to any subgroup. We did see in the 6 milligram there was a suggestion of liver toxicity and some VOD, handful, because we were well geared up to looking out for it. So 6 is okay, but since there's no outcome benefit in giving 6, you may as well just settle in a dose of 3, which is clean as a whistle as far as liver toxicity is concerned, even if they go to transplant, and even if you give it with intensive schedules like FLAG-IDA. We are currently testing a randomization between giving 3 milligrams on day 1 or day 1 and day 4. So this is to try and resolve the issue as to whether you need 1 or 2 doses. And that, I think, will finally position the optimal use of Mylotarg. The venetoclax, moving to venetoclax, and the fact that it's got accelerated approval is quite impressive in an unrandomized trial. This is the low-dose Ara-C combo. And what's important apart from the response rate here is the fact that these are older patients who you can get into remission by various experimental treatments, but the problem is they don't stay there. And it looks quite encouraging here in using the BCL2 inhibitor, that these patients, when they do get the response, they maintain the response. And I think that could be very important development for these patients. So that's going into a randomized trial now. Now, a few words about our experience in minimal residual disease. This was really started in the UK in the late 70s by George Yanossi. And the questions in AML are different from lymphoproliferative diseases. In AML, it's an art form in the eye of the investigator, whereas it's much more straightforward in some of the lymphoid malignancies. And so there's a question not only about the specificity, but also the sensitivity of pickup. And from a prognostic point of view, how much more does it tell us that, than we already know with an armful of prognostic factors? When should we do it? Both Dan and Roland referred to this issue, and that's not clear. Many groups do it at the end of therapy. And it's not clear when you get the most bang for your buck. We know it's likely to be prognostic, but will it be predictive? In other words, does it tell you what the right thing to do is, like the situation in APL, for example? So that's an important issue, and we should not jump to a conclusion that if you've got MRD positivity, it's going to benefit from a transplant or more therapy. Or on the other hand, because you're negative, you can back off from treatment. I think that would be a mistake. And so it's not, in that sense, should not be deployed as a routine, but it should routinely be in clinical trials so that we can find out where it sits. As treatment changes, so the MRD might change. We never found that MRD, incidentally, when we randomized between Mylotarg and nothing, MRD didn't pick up the benefit, which was very clear of a reduced relapse risk in the Mylotarg-treated patients. It will also generate additional costs, not just the cost of the assay, but the cost of reinvestigating patients and all this sort of thing, and the anxiety had been mentioned by Dan. So we're running a sort of public health trial in the UK where patients are randomized to be monitored or not monitored by either flow or molecular, if there's a suitable molecular marker. And the plan there is to the endpoint is clearly overall survival. Does having this available to you from a central lab help you? Does it improve the survival of patients? The health economists are involved to work out the additional excess costs that will cost to the healthcare system. And the psychologists are into the impact that will have on people's well-being in terms of worrying about their next assay, or indeed whether they're reassured by the fact that they're being so carefully monitored. So that monitor versus no monitor randomization is aiming for 660 patients to be randomized. And I think the accrual will be completed probably this year. So it's a sort of public health question, but it's rather simplistic because it's going to be in subsets that I think we're going to find the difference. Just this point about what you should do about it. Now, if it's embedded in a clinical trial where there are randomized questions, you may be able to connect the MRD answer to the benefit or not of a subsequent treatment. Now, this is a little bit of a lesson, however. This is AML-16, a study in older patients where a marrow is taken, the remission marrow is taken, and this is flow cytometry done by Sylvie Freeman's group on that marrow to tell us whether these patients were MRD positive or negative. And 50% of the patients in morphological remission were positive and 50% were negative. The investigators were not told about this, so it wasn't going to be anything to action. But in this trial, some patients were to get more or not consolidation, so they get intensification really. Now here you can see the outcome of the MRD status in that marrow. These patients in remission, this is their first marrow, and you can see that in fact there is a strong trend towards a higher relapse risk in the positive patients. And this impacted on a significant survival difference. Now, you might think, well, the MRD positive patients are the one that will benefit from the intensification after this point in their care. And the red line here is the consolidation patients, and you can see they did not benefit from adding further treatment. If you look, on the other hand, at the MRD, you can see it's the MRD negative patients that benefited from intensification. So don't assume that you've got to muscle in on the positives only. It could be that the MRD at this point is telling you these are the chemosensitive patients, and maybe you should also focus on getting their survival up further. And then, of course, there is the issue of what to do about the negative patients. This looks at younger patients in the current AML-17 trial. Again, the data is not fed back to the investigators. And this is looking in the top left panel at the first course, the cumulative incidence of relapse, and you can see that again we're seeing roughly half the patients, young patients, said to be in remission. 50% of them are also MRD positive, and that does make a small but significant OS impact that you see in the bottom. You also get further valuable information by looking after course 2, as shown in the right-hand panel. When you divide it by risk group, and this is the top left panel, is the CBF patients, and you can see there's a lot of them, some of them are MRD positive, and they have quite a high relapse rate. But it's well known that you can get these patients back again and salvage them, so it doesn't actually impact on the overall survival. On the right-hand panels, the cumulative incidence of relapse in the high risk in course 1 is shown there. And it doesn't make any difference to outcome, because bad risk are bad risk, even although they happen to become MRD negative after their first induction or second induction course. So the real group that may benefit, prognostically at least, and maybe practically to design treatment, is the intermediate risk group. And here you can see that there is a significant but smaller advantage in overall survival. And you've also, again, after course 2, pick up useful information. But what I think the important line here is the overall survival of patients who are intermediate risk but MRD negative on that first marrow. You can see that they have a 70% survival. So they're doing quite well, and you have to think quite seriously if it's your standard practice to, for example, transplant these patients. If we take that curve and censor it at transplant, the curve goes down. If we censor it at transplant, the curve goes up, suggesting that transplants might harm these MRD negative patients, but that's just... Here we have NPM1 and FLT3 status. You can see that in the left-hand panel, if the patients are intermediate risk, NPM1, MRD-ness doesn't make much difference. On the right-hand panel, if you're NPM1 but you also have a FLT3, it does make a difference. So again, that gives you further potentially useful information in classifying the risk of these patients. This looks at the wild type, and double mutant here, where it does show you that there is some impact of MRD-ness. So how does this get incorporated? Most of the European collaborative groups have incorporated MRD, generally not to react to it, but just to collect the information in the context of various other randomizations, which I think is probably what has to be done at the moment. The exception here is the Ho-von-Sack protocol, where the good risk patients who are MRD negative will go to an autograft. What I would have liked to have seen would be randomized to an autograft or not, so that you find out whether the autograft works in either group. So I think the controversy of whether it's routine, it should now be routine within the context of clinical trials, and that's really all I'd say. So I think the new stuff with FLT3 inhibitors does offer hope, and that hopefully there are better agents going to produce data shortly. The Vyxeos, there are concerns about the control arm. There are clearly on small subgroups, some groups that benefit, so its potential could well move into higher risk or different risk groups, even in younger patients. The IDH2 is a challenge. It's a very interesting phenomenon, what it's achieved, but it's going to be a challenge to do the prospective trial with so few patients hanging around. And maybe one initiative could be do a combination with small molecule plus chemo in these patients. I think we're all impressed by the BCL2 inhibition, and I would say that MRD is ready for prime time in the context of a clinical trial. This is a difficult thing to organize, is a bit of an art form in AML, but I think we're going to benefit from it once we understand what it means as far as treatment. Thank you.